Today, we're talking about gotchas in GLP-1 medications. It is the current darling of the pharmaceutical interventional world. And whether you're a prescriber or not, you need to be savvy about the common clinical conundrums that can arise with your patients and clients who are using GLP-1 agonist medications. And in today's broadcast, I'm going to give you 4 key considerations and talk specifically about what you want to be looking for and resolving in order to minimize these negative side effects on the people that you're serving in your practice. Welcome to Functional Medicine for Real World Impact, where we're diving into the complex, interconnected nature of health and disease, exploring not just theory, but practically what it takes to turn functional medicine insight into powerful, practical, real-world results. So please hit subscribe and let's get started. So first of all, let's talk about the oh-so-common complaint of nausea and dysmotility. This is quite challenging for many individuals who start using these medications. GLP-1 agonists are being prescribed for many individuals who are substantially obese, morbidly obese, and who are wrestling with entrenched type 2 diabetes. And we know that they're increasingly being prescribed as well for off-label, more minor weight loss types of concerns and considerations. And they are becoming very popular because they work. But let's talk for a moment about the simple physiology of GLP-1, which is an example of an incretin hormone that is naturally produced in the human gut, specifically in the duodenum, as well as other places, that helps to regulate motility and to tie our food intake to our glucose regulatory response. Normally, incretins are secreted in response to the movement of food coming out of our gastric cavity. And if we have slower gastric emptying, then we're going to have a more mild or lower incretin response, incretin synthesis, and therefore incretin signaling and lower insulin signaling. But if we have a more aggressive or accelerated gastric emptying response, it will pop a stronger, more aggressive incretin response in the small intestines, and that will have a stronger insulin signaling. Now, in the normal human physiology, there is a self-regulating process where if we have a surge of incretins, it is going to work to calm and slow that gastric emptying, and then there will be a lower incretin response. Well, it's this slower gastric emptying that is reducing appetite that is supporting so many people using GLP-1 agonists in order to lose weight. They simply don't feel like eating as much. And this lowers appetite and makes it easier for them to minimize excessive food intake. But the problem is that we're interfering with the body's normal self-regulatory pattern, because even though gastric emptying is being slowed, we keep taking the medication and we keep pushing higher levels of incretins in order to get higher insulin response. And the nausea and the dyspepsia that some individuals complain of is a natural consequence of the fact that that is what the medication is doing, is promoting upper GI dysmotility on purpose in order to create that appetite reduction. But as you know, likely from your practice, for some individuals, this nausea in particular can be extremely debilitating. And in some cases, the dysmotility can actually lead to distension and bloating that is really quite uncomfortable. And we find through the functional medicine lens that often individuals struggle with this so much more because even before using the medication, or maybe coincident with it, since they have begun the prescription, they have other underlying functional imbalances that are creating nausea and dysmotility. Ideally, through the functional medicine lens, we can help people to identify these factors before they start the drugs. We can work on improving them so they're way less likely to have symptoms downstream. But there are a couple of very common reasons why individuals might already struggle with nausea and overall dysmotility. And one of those that you want to be on the lookout for and learn to characterize and support is histamine overload. Histamine is a natural substance that the human body thrives with. It's a pro-inflammatory mediator and it supports our immune function, but it's also a signaling molecule for a number of key functions in the human body. But like so many other biochemicals, we thrive when we have a nice balance between the amount of a biochemical that's being generated or that we're being exposed to, alongside our ability to process it or degrade it. And so we have a balanced supply and demand, if you will, and we are able to well manage our histamine load. But individuals can end up with an overload of histamine, either because their body is being exposed to or is generating too much of it, or we have an impaired ability to degrade histamine. And women in particular, when they enter the perimenopausal time of life, largely the decade that is their 40s, often start to struggle with histamine overload. And this has to do with the shift of progesterone and estrogen that is naturally happening during these years. And women can end up generating more histamine than they did naturally in prior years. And they can end up with simultaneously impaired ability to degrade that histamine, largely through reduced activity of an enzyme in the small intestines called diamine oxidase that would normally degrade histamine. And so this is an important consideration because many women who are taking GLP-1 agonists are in those perimenopausal years. And the further they move into it, the likelihood that they're going to struggle with increasingly higher levels of histamine overload. And histamine in the body doesn't just promote nasal respiratory congestion, which is what we often associate it with, right? Chronic postnasal drip, or some type of mucus or phlegm challenge in the body. But histamine overload can promote a rich diversity of symptoms, including migraine headache, anxiety and hypervigilance, including poor sleep. And also in the gut, it can promote both nausea and dysmotility. And so if a woman, for example, is already struggling in her perimenopausal years with some histamine overload, and then she adds these medications on top of it, it's almost a given that she's going to wrestle with some pretty debilitating GI symptoms. And so we want to be looking for the roots of this and be able to help her, whether it's using natural antihistamines such as quercetin and bromelain, or actually using overt diamine oxidase supplementation in order to minimize histamine load in the gut, especially when there is an impaired ability to produce diamine oxidase, especially as we age. And so think about this for perimenopausal women. We often need to support them with histamine overload. But it's also true that many women and some men wrestle with hypothyroidism, especially subclinical hypothyroidism. And this can also promote dysmotility that GLP-1 agonists, again, are just going to further fuel. And through the functional medicine lens, we always want to be looking for subclinical intracellular hypothyroidism, especially when people are presenting with some of the same types of symptoms that might have set them on the path to becoming markedly overweight or developing type 2 diabetes. They have lower energy. They feel more sedentary. They have trouble maintaining their weight. They might feel cold on a regular basis. There might already be, in general, just trouble maintaining an optimal body temperature. All of these are classic signs and symptoms of hypothyroidism, and subclinical hypothyroidism is quite rampant. And we need to be running full thyroid panels in order to identify where this might be at play, so we can identify the particular type or profile of hypothyroidism and adjust it. But the point being here that nausea and dysmotility is quite common in individuals who are using GLP-1 agonist medications, and we can best help these patients and clients by getting to the roots of why they uniquely have it. Another common driver for nausea, especially idiopathic nausea, is actually insufficiency of vitamin B6. This is an essential nutrient for catalyzing enzyme activity in the body, and we need adequate levels of vitamin B6 in order to synthesize key neurotransmitters that affect gut motility, like serotonin. We also need B6 in order to make the diamine oxidase that I mentioned earlier. And you might be surprised at the number of people in your practice who have suboptimal vitamin B6 status. This is especially a risk in women who have been using oral estrogen-containing medications for an extended period of time, like birth control pills. And so we want to be thinking about how these fairly common lifestyle choices and circumstances might be depleting core nutrients. An also common mineral insufficiency in the American population in general is magnesium. And inadequate levels of magnesium can cause trouble with balanced muscle contraction and relaxation throughout the body. And this is also often at play in chronic GI dysmotility. So that's the first one I want you to be aware of. The second one is maybe the obvious elephant in the room, which is malnutrition, because GLP-1 agonist medications work and they dramatically reduce appetite. And unfortunately, when they are used in the typical dosages that are being prescribed, they suppress appetite to the point where individuals are markedly under consuming key micronutrients. And in fact, the typical recommended dosage is so high that the patient doesn't actually have to adopt any type of marked dietary improvement at all. Unfortunately, nominal dosages of this drug promote the false belief that people can just eat whatever they want and they keep losing weight. We see this messaging, these conclusions being promoted all over the internet, and it's not doing these people a service. Because at the end of the day, if they stop the medication at all, they are going to have a rushed return of their prior levels of appetite, their prior cravings, and they haven't learned any new lifestyle habits to help them navigate a new norm that would allow them to maintain the health improvements that they've made. Anytime we are using a pharmaceutical solution that removes any responsibility from the patient to take ownership of their health and to make tangible, sustainable change in their life, I think we're doing them a disservice. It's promoting their belief in a magic pill that takes away their need to change, their need to make shifts in their choices. And I actually believe that these medications are much more promising and will ultimately do much more service to the people who are taking them if we use them in markedly lower doses that still require people to pay attention to their habits and to make mindful choices about their foods, to not reduce their appetite so much that they hardly feel like eating at all, in which case they're way more likely to be continuing to eat nutrient poor, highly refined, hyperpalatable foods because their appetite is so low. And they're not getting the macronutrition or the micronutrition that they need. Yes, they're losing weight because of extreme calorie deprivation, but they're not learning new habits. And even in the interim, they're not fueling their body in order to support their biochemical thriving. So I believe we need to be looking much more carefully at gauging individual response to these medications and managing dosing so that people get the hand up that they need, the increased incretin signaling that gets a better insulin response in order to manage blood glucose, but helps them to just take the edge off of their appetite so that their caloric intake can better be matched with their overall level of activity and their metabolism can find a better balance. Research actually shows that GLP-1 agonists do not overtly themselves necessarily improve insulin sensitivity at all. But by promoting weight loss does improve insulin sensitivity over time. And so we need to be paying close attention to what are people eating. And just like we would do for bariatric surgery, give people targeted guidance on what to actually consume. It's especially critical to make sure that individuals are getting in enough protein, because while we can store some excess sugars as glycogen, and we can certainly store lots of fat in the body for later usage, we have an incredibly limited ability to store amino acids without going into a catabolic state and having to break down our own tissues in order to mobilize amino acids. So we need to be consuming our protein. I think we need to be giving people guidance around eating your protein first, making sure they're taking key core supplements to get the micronutrition they need. Pretty much anyone, in my experience, on a GLP-1 agonist needs a good, solid, rich, high-quality multi-nutrient. That includes both vitamins and minerals. They also need an essential fatty acid and fat-soluble vitamin support in order to make sure that they are getting those key fats. And then after the core nutrients and the protein, getting in vegetables, because phytonutrients from a colorful diversity of plant foods are also in their own way a collective basket of essential nutrients that are needed to fuel the antioxidant pathways in the body that help us to counter pro-oxidant damage. So malnutrition is a much bigger risk than we might think. Yes, even while someone is morbidly obese, many individuals are having such a suppressed appetite that they're not getting the basic nutrition that they need to run their biochemistry during this weight loss process, which is going to leave them with other functional imbalances on the other side. The third thing that I want to encourage you to look for and think about is the notion of hypoglycemia. Because yes, these GLP-1 agonists are directly affecting first phase insulin signaling so that we get a more aggressive response from the pancreas. We get higher levels of insulin being put out. And research shows that people who have type 2 diabetes, for example, by the way, they aren't necessarily making lower levels of incretins. That really depends on the study the research that's being conducted. It varies quite a bit depending on the sample group. But what we do find is that there's lower incretin signaling happening in individuals who have type 2 diabetes. And so popping in these GLP-1 agonists, right? These basically incretin mimicking medications helps to naturally pop that stronger incretin signaling. So you get a greater insulin response. But in some cases, these medications are being given to individuals who may be quite overweight, but they already have a significant insulin response. I've encountered a number of these individuals, perhaps you have as well, where the fasting insulin or fasting C-peptide response for these patients was not actually measured prior to the medication being delivered. After all, individuals can have all sorts of different blood sugar levels aligned with all sorts of different insulin levels behind the scenes. In some cases, individuals may have markedly high blood sugar, but behind the scenes, their pancreas is still responding very strongly, and they already have hyperinsulinemia. And giving the GLP-1 agonist drug is going to make that hyperinsulinemia even worse. And again, while this might suppress appetite and promote weight loss, the higher levels of insulin behind the scenes can actually be promoting both hypoglycemic episodes, which can, as we know, be quite dangerous for individuals in terms of promoting dizziness or cognitive impairment. Individuals may also feel very emotionally labile or anxious during these times. But higher levels of insulin is also naturally going to promote adiposity. And individuals using these medications can be getting a negative shift in their body composition while their weight loss is happening. They're actually gaining body fat as a relative percentage, even while they are losing weight. And so we want to be assessing and looking for actual insulin status before we use a medication that is artificially going to pop it to be more aggressive as a result of the drug. Now, yes, plenty of people with type 2 diabetes who have markedly elevated blood sugar have pancreatic insufficiency, and their pancreas is now failing to respond appropriately or sufficiently to the glycemic load. And so pancreatic response needs to be stimulated. But that is not always the case. People can have low insulin response and high blood sugar. They can have moderate insulin response and high blood sugar, or they can have really high insulin response behind the scenes. But the glycemic load is so strong from their stressors, from their diet, that the insulin is simply still not enough in order to manage to accommodate that glycemic load. So we want to do our due diligence to really understand what's actually happening with this individual in terms of pancreatic response before we use a medication that's going to pop the pancreas to be even more aggressive. After all, if there is insulin resistance behind the scenes, we can work on multiple pathways to help improve that well beyond the weight loss that the medication is going to promote. And then the fourth thing that I really want to make sure that you are aware of for these medications is, in my opinion, perhaps the most alarming risk of using these drugs. And this is, again, a consequence of its primary mechanism of action. GLP-1 agonists are promoting weight loss by causing upper GI dysmotility on purpose. And this is, again, causing the lowered appetite. But in causing lower or slower gastric emptying, we must remember that the effects of the medication are not just limited to the stomach and the duodenum. These medications are also slowing motility through the hepatic biliary tree and making more sluggish the emptying of the gallbladder. And again, if this is on top of other sources of dysmotility like hypothyroidism, then it's going to be even worsened. And so the liver gallbladder axis becomes quite vulnerable to congestion and blockage as a result of using these medications. Well, let's pause for a minute. Which population is particularly vulnerable already to having hepatic biliary congestion, starting with fatty liver? Well, it's individuals with metabolic disease like type 2 diabetes. And so many people who are going on GLP-1 agonist drugs already have some degree of a fatty liver. They already have some degree of hepatic biliary sluggishness, and they may already be struggling with suboptimal emptying of the gallbladder that over time is naturally going to be more likely to promote eventual crystallization of gallstones that can build up and promote blockage and the eventual development of gallbladder disease and the need for a cholecystectomy. And so if we aren't assessing Fatty liver, hepatic biliary congestion, gallbladder emptying, and looking for not only labs, but other qualitative signs and symptoms of these dynamics. If we're not looking for them in advance so that we can help to resolve them before people start using the medication that's going to make them overtly worse, then we may be contributing to what research shows is a marked increased risk of eventual gallbladder disease and cholecystectomy in people who are using these medications. And so this is a particular area of vulnerability you want to be on the lookout for. When we assess and find even early stages of fatty liver or poor gallbladder functioning, there are a number of different targeted interventions we can make in order to remove that, to resolve that, which we'll talk about in other videos. But we want to use care in ideally resolving this functional imbalance before individuals start using the drugs and making the situation even worse. And again, this is where reduced dosages can also make a huge difference because the effects are not as severe. The upper GI dysmotility is not as severe when we use lower dosage, when we think about small or even micro dosage of these medications. Dr. Tina Moore in the functional medicine world has done an awesome job promoting the benefits of these medications, but really teaching us how they can be wisely used in much lower dosages to get the beneficial effects, but avoiding so many of the known risks and negative complications of using them. And again, we always want to think about leaving patients and clients empowered, and in fact, leaving them with a responsibility to truly partner with you as a practitioner to make sustainable lifestyle change. The only way we ever have durable, resilient change in our health is by taking ownership of our day-to-day choices and making different choices, right? So much of what is normal in our cultures, our food, our environment, our behaviors are actively promoting disease. In fact, metabolic disease is incredibly common, as we know, in our populations. All you have to do is make normal choices, eat the normal foods, experience the normal stressors, do the normal behaviors, and metabolic disease, it will be an eventuality in your life. Unfortunately, that is the American way. And so our opportunity through the functional medicine lens is to empower people to make abnormally healthy choices in order to earn abnormally healthy futures, in order to have an abnormally healthy, high vitality life experience that is not plagued by debilitating symptoms, especially during the prime years of their life. And so we want to use these medications responsibly. And whether you're a prescriber or not, you have the opportunity to educate, inspire, and empower the people you serve to understand the necessity of them taking responsibility for their choices to make sure that their changes in their health, the improvements that any pharmaceutical might give them, can actually be sustained through a shift in their physiology and biochemistry that happens because they make different day-over-day choices. So I thank you so much for joining us here at the School of Applied Functional Medicine. We're posting content on a regular basis to help you as practitioners to do your best clinical work, to not only optimize the health of your patients and clients, but help earn you that deep satisfaction and fulfillment that you crave. Please hit subscribe, and I look forward to being with you next time.